So I want to talk about brain mets because some of the new data, we're finally seeing some changes, and some of it's really surprising to people. Um, so the first thing I want to do, I'm going to spend actually about half of this time talking about updated prognostic data, because of course that's what a lot of us get asked when we meet these patients and diagnose them first in the hospital. So I want to do a quick little poll. If we said just all comers, patient with a newly diagnosed brain metastasis, let's talk about what we think the average prognosis for the patient would be, knowing that they vary tremendously, but this is the data we're going to go over, because it used to be very like the same for several decades what the prognosis was. So raise your hand if you met a patient with a brain met and they said, how long do you think I've got? How many people would say 3 months? 6 months? 9 months? A year? Okay. Year and a half? 2 years? Okay. Either half of you are wildly optimistic or half of you are just not going to raise your hand no matter what I say. All right, so let's talk about that data because it's very interesting. And now we have a lot more detailed data rather than very broad predictions, which used to kind of be broad enough that you could apply them to anybody. So as you guys know, these are really common, a lot more common than the primary brain tumors. There's a question whether they're becoming slightly more common because as systemic treatments get better, more and more people are surviving longer and hopefully better, but then ending up having brain mets. Brain mets end up affecting about 10% of adults who have cancer, so they're a rather common complication across the board. If you do autopsy studies, and these were older studies, but if you do an autopsy of people who die of cancer, about a quarter of them will have brain mets at the time of their death, some of which were occult and asymptomatic. They are obviously a very major cause of morbidity and mortality. When they occur, they are often the direct cause of death for the patient, direct or indirect, depending on how you define those terms for people with brain mets. But complication rates certainly go up with falls, with pneumonias, with trouble with breathing, and with cognitive problems. There are also, if you want to start thinking about cost for patient care, patients with brain mets have much more costly care because often they cannot be in the home, or the burdens on the caregivers in the home are much more substantial than people with cancer at other parts of the body and in other sites. So by far still, the most common cause of brain mets is lung cancer. I think all of us are hoping and expecting that number to at least slightly decline in kind of the tag along after drops in smoking rates. A thing to remember about people with lung cancer, though, is that about a quarter of people who have lung cancer are never smoked their whole lives. Some of those are secondary smoke, air pollution exposures, but up to like 20% of patients have a kind of lung cancer that has nothing to do with smoking. So many of you may have heard there's a kind of lung cancer that often occurs in younger women, usually in their 20s to 40s. For some reason, it has a higher incidence in people of Asian ethnicities that's due to a mutation in a molecule called EGFR. So that kind of lung cancer is completely unrelated to smoking, and it actually has a very different treatment and prognosis than other ones. The second most common is breast. Probably as lung cancer rates decline, breast will become the more proportionate cause of brain mets. And then even though melanoma is less common than some of the other things on this list, it seems to have a propensity to spread to brain, so it's usually third on the list in most of these things. It used to be that cancer of unknown primary was relatively common. With improvements in molecular pathology and genetic testing and imaging modalities, it's really shrinking. We probably only see a couple of these now a year. So cancer of unknown primary is becoming far less common than it was in the past, thanks to our pathologist colleagues. As you guys know, for anything in neurology, it's all about location. Headaches and impaired cognition are by far the most common presentations. Seizures, this number always surprises me because I just feel like everyone I meet is diagnosed because of a seizure. But this is the number, allegedly. But it always seems to me like it's much higher than that 18% that's quoted in the studies. But multiple studies come up with a similar proportion. Pre-therapy, you can see responses to treatment. This was a patient of mine from New York who was in her early 50s with breast cancer and had brain mets from diagnosis. And as you can see, this was what we call like miliary leptomeningeal disease. She had many metastases. And 1 year later, after she did whole brain radiation therapy and hormonal therapy for her breast cancer, she had a wonderful response to her disease. She was virtually asymptomatic, and if you met her, you wouldn't know anything had happened to her. So there is responses to treatment from whole brain, despite often the negative connotations that people discuss whole brain with. So in the 90s, what you would have said about prognosis and what a lot of us learned in school was that untreated, a patient with a brain met was likely to be dead within a month. With just steroids and whole brain radiation, which were the only effective modalities for decades and decades, that prognosis changed to about 4 months on average. And that's taking all comers, whatever the cause is, age, how symptomatic they were. Even back then, long-term survival was possible, but it was quite rare. And basically, it was usually people with breast cancer, because the more common causes of breast cancer often respond very well to radiation. Hormonal therapies have been around for a while. So most of the people in the old days in that 8% alive at 2 years range would have been younger, healthier women with breast cancer that's not triple negative. But even before the modern treatment modalities, there was always this small but real subset of people with truly long-term survival from brain mets. So people often don't think about that number of what's possible. So again, these are older data, but the kind of first initial way coming up into the 90s that we would talk about prognosis for people with brain mets was based on very, very simple, basic data of their KPS. I don't know how much anyone talks about KPS, but in oncology, it's the most commonly used status for functional status. Basically, if you are asymptomatic or very minimally symptomatic, like you say you have a headache or some numbness, but on exam I wouldn't find anything, you're a 90 to 100. If you have some symptoms that I can find on an exam, but you can take care of your ADLs completely by yourself most of the time, you're probably a 70 to an 80. When you drop down below 70, that means at least in part of your ADLs, you probably would need somebody's help with something, but you're mostly up and about, would be a 60. 50 is an easy number. 50 is basically, are you in bed for more than half of the day or less? That's where we divide along the 50 line. When you go less than 50, you're talking about people who really need to be in an inpatient setting and are having acute issues, so people who are pretty impaired. So that's our KPS scale that we use and that's still used really across all of oncology. So it's basically based on KPS and age and whether your systemic disease was active or unknown. And you'd class people into these 3 prognostic or RPA class categories. This was data derived from studies and fed into nomograms that were verified. And this was how trials were designed going up into the 80s and the 90s. And the median survivals, as you can see, were pretty in line with those numbers that we just talked about. So again, this is the older data and what a lot of us would have learned and might talk about until recently. So additional prognostic factors back then were really not thought to be effective. They didn't show up in the data, but that's what has been changing in now. So going into the real world, there's a new thing called the GPA, the Graded Partition Analysis. So basically, based on those old RPA classes, the RTOG, which is a large radiation treatment oncology group, taking nationwide studies, sometimes including international stuff up into Canada, did large studies, a lot of them based on whole brain radiation, SRS, which is better for who. So these are huge studies and multiple ones. The thing to remember is this is pretty close to real world data, but it's not applicable to every single patient. Patients who were extremely impaired, people in those really low KPS functional status were not in these studies. So there's an inherent bias in these studies and their number when you go to apply them to the full spectrum of patients that we encounter. Patients who were in the worst categories would not have been in those studies. So there is a little bit of a bias there that's important to remember when you think about prognosis. So these don't apply to the extremely sick patient that you would say, are we even gonna really think about treating this person because they're so ill? And what they come up with, and these, I don't know how well you guys can see this, but we'll have some larger ones later, is a bit surprising. And basically, you have to approach people with different kinds of cancer very differently. But within the cancer type, if you know it, you can break down by a couple small discrete numbers how well or not well they are likely to do, especially for the most common cancers. I think the biggest surprise in this data is in the old way that we would think about it, we'd say, well, what's the status of their systemic disease? In the new prognostic category, the only cancer for which that actually is relevant is lung cancer. In every other cancer, when we talk about prognosis for brain mets, whether they have active disease or not in the body actually doesn't matter, which is kind of surprising and hard to conceptualize, but that's what the numbers said. In lung cancer, whether they have active systemic disease does make a difference. It's one of the major criteria that stratifies people by risk. For everything else, it's basically based on number of brain mets. KPS is important across the board, so that's why it's a good thing to think about how functional is this patient, or how functional would they be after a day or two of steroids. And then in some of the categories like breast, you really get into, you need to know which subtype it is, which often if it's a new diagnosis, we don't know yet, but it makes a big difference whether they have triple negative, HER2 new positive, or hormonal breast cancer. So sometimes you don't know that right away, and you really would wait for that data before you would even think about talking about prognosis. So for breast cancer, again, that's the important part. The terminologies used in the literature I think are really confusing. They talk about luminal this, luminal that, basal, but basically what they really mean is hormone receptor cancer, HER2 new cancer, or triple negative cancer. Triple negative cancer is still, obviously the worst category to be in. There aren't very many effective treatments, and those people have a significantly worse prognosis. People with HER2 new positive cancer, we kind of entered an era after this data came out where there are several very effective treatments for HER2 new positive breast cancer. It does have a propensity to go to the brain, but some of the treatment categories that can be incredibly effective in the body, only some of them are effective in the brain. So when I talk to our breast oncologist colleagues and a patient with a brain met, we're often kind of deciding which disease is more important to treat first. The body, for which you usually choose things like trastuzumab or Herceptin, or are we going to focus on the brain disease, for which lapatinib is probably more effective with better penetration? We're getting more drugs for HER2 positive breast cancer literally every year. Brain disease is becoming more of a focus, so we're getting a little more data. Obviously, I'd like to have more about what drugs and agents are more effective in the brain, but some of these people can have really stunning responses to just lapatinib, which is, the brand name is called Tykerb, in the brain, that are extremely durable. So literally taking a pill twice a day all by itself can be sufficient to control systemic and quite significant brain disease for pretty long periods. The luminal A, the hormone receptor positive, is actually the best prognosis, both systemically and in the brain. It's also the most common form of breast cancer, especially in older women. Hormonal therapies alone, this has long been kind of a secret to people, but hormone therapies alone can be quite effective in the brain and quite durable. So people often forget that. The oncologist colleagues too, we often talk about, well, this person was on hormonal therapy and they had progression in the body, and then they're taken off of the hormonal therapy and later develop brain mets, and we talk about, well, should they just go back on their hormonal therapy or not? But it can be quite effective. Unfortunately, there's very few kind of real good trials and studies establishing that, and there probably never will be because no one will fund them anymore. But it's kind of, I think, surprising to most people that therapies that we think of as very simple and easy can be quite effective in patients with brain mets from breast cancer. Most breast cancer is actually quite radiosensitive too. So with radiation alone in any form, whole brain or SRS, all of the breast cancers should be predicted to respond and hopefully have symptomatic relief from radiation by itself. And then you can just rely on the chemotherapies to hopefully maintain that response for a longer period. I think this comes up a lot too when you talk about, should we do whole brain or should we do SRS, because you really want to think about prognosis. For patients who you expect to hopefully survive and be living well for longer periods, the longer you live after whole brain radiation, the more likely you are to develop memory problems. They don't happen right away. They typically start 9 to 12 months later. So all of us, I think, have met some of these people who had whole brain radiation for multiple brain mets from breast cancer, and they have good disease control and no disease activity in the body or the brain, and then they live for years, and it's years later that their memory and cognition is progressively devastated from the whole brain radiation therapy. So this is probably should be a really, really important part of using this prognostic data to stratify people for which treatment, whether it's whole brain or SRS, is best for them, because you really want to have long-term goals for the people with hormone positive or HER2 positive breast cancer. Triple negative is a lot harder category to address both in the body and the brain. So for lung cancer, the numbers are also getting a little bit better, but again, it's becoming important which subtype they have. That really barely even shows up in the data that is from 2010 to 2012 that I'm talking about. So this data is already becoming outdated. So depending on the GPA category, which does depend on status of systemic disease, KPS, and age, these numbers also, I think, are surprising to many people. You know, if you basically look at these numbers, we'll see if this works. So the 50% line is about here. So that would be your average prognosis if someone said, how long do you think I got? Hopefully you'd have a little spiel about what statistics mean. We're not gypsies with crystal balls. These are not absolute predictions. But people who have even modest good functional status and are not elderly, the 50% line really approaches a year. So most people are on this gray line in terms of their GPA status. You know, the red line is people who are elderly, extremely impaired already, but most of the patients would really be on this blue or the gray line. And so we're talking about 50% prognosis being closer to a year for people with lung cancer. And then yellow, so the person who kind of is relatively asymptomatic, only had a headache or a seizure, but is totally functional, would be on this yellow line. And there the 50% is really about a year and a half. And again, these numbers are outdated and they're improving. So, you know, and these are not like fancy cherry picking patients. So when you think about someone's functional status, these are the numbers that we should be thinking about. The breast numbers that we kind of went over, these are the actual curves. Again, you know, they're already probably changing and improving, but talking about somebody who's really impaired, someone with triple negative breast cancer, the 50% line is probably 6 months, so closer to the old data that we think of. But then somebody with hormone receptor positive or HER2 breast cancer who has relatively few symptoms, the 50% lines are a year and a half, and people who are, you know, minimally symptomatic with hormone receptor positive breast cancer, which is one of the most common categories of patients you'll encounter, the 50% line is going out to 2.5 to 3 years. So I think these numbers are pretty different than what people think of or are aware of. And these nomograms are available online. You can go and literally click, you know, brain met, prognosis nomogram, and boom, pull them up. And you really only need a couple of data points to really talk about these numbers. They're not the numbers that your patients find on Google, though. Even though they're easy to find, if your patient goes to Google, which is what they all do and their family members, and they type brain met prognosis, almost always what comes up are the old numbers. So that's what they're finding, and they're aware of whether they tell you that or talk about it or not. But it's often what's fixed in their mind, and then they're making treatment decisions based upon. This is the data we kind of already talked about by subtype, but really it's just what kind of breast cancer is it? What is their KPS? That data is easy, simple to know. And then the age is actually kind of a relatively small factor, but it is a minor factor in that decision. So moving out of the categories, the other thing I'd add that's not in this data is that lung cancer also really now is stratified by type. Patients with EGFR positive lung cancer have a naturally better prognosis. It's a slower growing tumor. It has much more durable responses to any form of radiation, and some of the EGFR-directed therapies can be very effective both in the body and in the brain, but it's becoming like HER2 positive breast cancer, where often we're modifying the systemic therapy to focus on the brain and seeing better long-term results. So I think the next time they look at this data, lung cancer will also end up stratified by type with very different prognosis, purely based on is this EGFR positive or not. And EGFR positive lung cancer is quite common, so it's not a rare disease by any means. So symptomatically, you guys know all of this, but it's worth reviewing. The number one thing we do is we put everybody on steroids. The data is very clear that you should not be using prophylactic anticonvulsants for people with brain mets. It's a guideline from our Neurology Society based on older data, but quite reliable data. Even the data about prophylaxis post-craniotomy is kind of iffy, but it's generally routinely done, but certainly you couldn't claim that it's proven evidence-based, although it has kind of become standard of practice because of practice patterns. So anticonvulsants should really only be used in people who have a history of seizures. People tried EEGs to predict who's going to seize. It doesn't work. People said, well, obviously people with temporal lobe lesions are going to seize. It really doesn't predict in any reliable way. So I struggle with these conversations with people because there's always somebody in the family that says, oh, should they be driving? Tell them they can't drive. Tell them they can't drive. So we talk about people with brain mets have a incidence of seizures that's about in the 20% range if you take all comers. So do we make everyone say, oh, you can't drive for that concern? I don't know. I mean, yeah, it's a concern. So I really just talk about the numbers and shrug a little bit and say, yes, I'm worried, but I'd be more worried about you texting while driving, or in Washington State, driving while you're stoned. Because those numbers are probably also about 20% for the general population. One thing I find very helpful, though, is if you often interview these people carefully and talk to them about symptoms of occult seizures, you will elicit one, that people have been having a little aura that they didn't know what it was. So it is worth doing kind of a thorough history on these people with both primary and metastatic brain tumors, because often you do elicit one that the patient would say, no, I didn't have a seizure, and then you describe symptoms of auras, and they'll say, oh, I did have something like that. So I really like taking kind of a little history about that, and it's often helpful. And if there's any question, then I do obviously treat them with anticonvulsants. So definitive treatment, still whole brain radiation therapy can be a very effective modality. The studies that all this prognostic data is from were mainly trying to tease out, is SRS better than whole brain? And if so, for whom? That debate is still completely out in the open because in all these studies, part of the problem was they pooled everybody as if they were all the same, which you know is a big no-no in studies. But that's what they did, unfortunately. So if there are groups that do better with one versus the other, it all got lost in the mix. But most of us who deal with these patients kind of know what's better. It's surprising, though, that despite everyone dealing with a mix of patients, there are certain centers where people kind of have their own bias. Hopefully, we will finally update this data and get good data that's stratified by the tumor types. But certainly the people who have a better prognosis, who we now should be able to predict, should probably be being treated with SRS more. The exception to that I'm going to talk about is it really, really, really depends on what type of tumor you're dealing with and how radiosensitive it is too. Combination modalities are almost always more effective. Surgery is incredibly important for people, especially who have a symptomatic MET or something that is likely to become very symptomatic in the near future and can be safely resected. So many people will get treated with multimodality therapy. Even when you're moving into the palliative range for symptomatic relief, surgery is almost always the most effective treatment. SRS has less risk, but it doesn't have the immediate effect, especially when you're dealing with a large, bulky tumor in a tricky area. And we're really entering a period where there are some effective chemotherapies, which was not true even 10 years ago. So we're going to have to figure out how and when to integrate those into the mix for particular patients, especially some of the molecular targeted therapies. So the other thing that's kind of changing is the usual modus operandi of the oncologists is put someone on a therapy. When they fail it, assume it's failed and never think about it ever again. They failed that 3 years ago, don't bother. It's pretty clear that what evolves on a molecular basis in the brain is often quite separate than what is evolving in the body because the brain has been protected. So often you're seeing people rotate through a HER2/neu or an EGFR therapy that the body became resistant to, but if you redo the molecular test to look at these predictors in brain tissue, from a resected MET or sometimes even from cytology from the fluid you can get it, they're still going to be sensitive. So that's not rare. It's probably much more common than people think about or realize. And it's probably, at least to me, I often say I want to get new tissue from the brain to really check this to figure things out. So we may end up rebiopsying people in whom we already know what kind of cancer they have, but we want to get the molecular data on the brain to help guide possibly effective therapies, which is not something we would normally do. So for the EGFR positive brain tumors, erlotinib is still, can be quite effective in the brain, but you have to dose it differently to get it across the blood-brain barrier. Most people really do tolerate it pretty well. There's a rare kind of molecular lung cancer with ALK mutations that can have stunning responses to a simple oral agent called crizotinib. The rest we kind of talked about, the use of hormonal therapies, and in HER2 new lapatinib can be very effective for long periods of time. It has some GI toxicities that can be a struggle to get patients to an effective dose. But if you're kind of know how to manage those GI toxicities, most people can tolerate it pretty well, but it takes time to work on. Melanoma is also going to be the category that's going to completely split and change the next time we look at data like this. BRAF mutant melanoma is not that rare at all. It's relatively common, especially in younger people, and it can have stunning responses to BRAF-directed therapy, both in the body and in the brain. We still don't have good data about whether you need to modify the BRAF inhibitors, but we now have 2 that work differently, and they have sub-agents that you can give with them to try and delay or prevent resistance. So in the next thing, we'll also have melanoma probably split into 2 categories based on their BRAF status. The other thing that has now come of age that didn't exist when this data came out is the use of immune checkpoint inhibitors. They first came out and were proven effective for melanomas, kind of across the different subtypes. It's very clear that they can be effective in the brain in a small subset of patients that we are not very good at predicting who's going to respond to them. It creates a huge challenge in interpreting their MRIs because these are agents that boost the immune response. So it's very common to see inflammation and kind of pseudo worsening of tumors that can be very symptomatic. So you have to employ the immunotherapies for the brain met patients pretty carefully, but you can see significant and durable responses to the immunotherapies. So melanoma is probably already substantially changed, and that's a different way we already approach these patients that may evolve in the future. We're just starting to get data on using those same immune checkpoint inhibitors across the board. In breast and in lung, they probably have significant efficacy in brain mets. Those trials are ongoing, but probably we're going to start employing those agents in those diseases too and adding another effective treatment to the arsenal for systemic therapy. Colorectal and GE cancers are kind of less common. The thing I left off of here that's also surprising, renal cancer used to be kind of the worst when you had brain mets from it. However, some of those patients, it's a very radio-resistant disease, but if the lesions are small enough, these people who get SRS and go on one of the molecular therapies for the systemic disease can have incredibly durable responses for years, which we would never have said 10 years ago that if somebody had a renal cancer, they might be alive and well years down the road. But it's kind of become the norm, especially with one of the drugs called pazopanib. So these people get their SRS, and then they take a pill every day, and it's incredible really how good they look for how long. Symptomatic treatment, the steroids is worth stopping at because it's always the thing that comes up and that we're always doing. Kind of my bottom line is there's no magic to steroids. The kind of boundaries I'd put on it is the surgical doses of like 6Q6. That's really important if somebody is herniating and you're about to take them to the OR, but virtually any other patient should not stay on 6Q6 forever. That's the worst when I see that. They get put on it and then everyone's afraid to taper them. People should always, always, always be tapered. The vast majority of patients should be able to get by on daily or BID at the most dosing. I just make these numbers up. I don't have any magic knowledge of these things, so you should make them up too. But the principle is give them a sample dose of about 4 to 10 milligrams based on how severe their symptom is. If it doesn't help their symptom, do not continue it. Just because the radiology report says edema, that's not it. You should be treating the symptom, not the picture or the radiology report. So give them a test dose. If it doesn't help their symptom, don't continue it, please. That happens all the time. And then whatever is enough to treat their symptom, go a little higher to see if you get more symptom relief. And if you don't, start the taper. And it's all just totally made up. I usually tell people go down by 1 or 2 milligrams a week. Once they get recurrent symptoms, you have found your minimum necessary dose. You go back up and then stay there for a good long while. If they respond to an effective treatment, then you want to wait a little bit and start a taper again. So that's really the only magic to steroids. It's unfortunate. Most people are left on too high doses of steroids for far too long. and then they end up getting all the complications, the mania, the insomnia, the mood issues. Steroid myopathies are incredibly disabling. They can happen really, really quickly. And then someone's KPS sucks, and then they can't get an effective treatment because people say, oh, you know, you're not so good. People end up stuck in inpatient rehab and nursing homes because of a steroid myopathy. I mean, that is really, really, really common. If they're having insomnia, they are miserable, absolutely miserable. I feel like I spend a huge amount of my time just treating steroid complications. But it's really doing a disservice to the patient. So it's important to focus on getting them off steroids and recognizing and treating steroid side effects. The one thing that often gets forgotten is people who remain on steroids higher than about 6 to 8 milligrams of dex for more than 30 days, they have an uncommon but significant risk of PCP or PJP, if you want to be really technical about it. So people who are going to stay on high-dose steroids for longer than a month probably should be on Bactrim prophylaxis. You know, we see tons of thrush, tons of cold sores, shingles outbreaks. So steroids, my colleague from New York, Mary Welch, kind of would give a whole talk based on steroids, and she called it the good, the bad, and the ugly, because they also get their moon phase. Patients hate steroids. So you always want to minimize their use as much as possible. So the anticonvulsants we kind of talked about. The perioperative data is literally made up. There's only one trial really supporting its use. The one possible exception that would be melanoma. The melanoma patients have a much, much, much higher incidence of seizures than anyone else. It might be the one category that should be put on prophylactic antibiotics. So it's one kind of data point to consider. Some of our patients are going to get surgeries. They're going to have swallowing issues. So you want to think about picking an agent that can be used across a wide range. Interestingly, when people go into hospice care, seizures often, they're a big concern in hospice, but they're seldom a huge problem. But you have to make a plan that hopefully will continue through the hospice phase for patients that you think are going to go down that route soon. The thing that has become incredibly, incredibly complicated is picking an agent that's not going to interact with their chemotherapy. And you really need to work with the oncologist and usually the pharmacy, because your oncologist typically won't know about the antiepileptics. This is why Keppra is great, but also awful, because it becomes so easy that people just stick to it because they don't have to worry about the interactions. But a lot of patients don't like the Keppra, and then when it doesn't work, it becomes a problem because no one knows what to pick. But if you work together with the oncologist and with the pharmacy, actually the oncology pharmacy, every time a molecular agent comes out, nobody knows the interactions. Like the HIV therapies, they have tons of interactions with the antiepileptics, and they're really complicated. But I think that shouldn't be a reason to not use some of the more tolerable and sometimes more effective antiepileptics. I usually pick an antiepileptic based on symptom relief, trying to kill two birds with one stone. So for patients with headaches, I'm often thinking about Topamax and Depakote. For people with neuropathic pain from their chemotherapy, I'm trying to think about Depakote again, Lyrica and gabapentin, although they're not great seizure drugs. Insomnia and anxiety are incredibly common and often due to steroids. So if I can find a way that using certain antiepileptic is going to help a symptom my patient is dealing with, that's usually what I use to pick what treatment I want to do, and then kind of verify and check around the interactions. So this is an old table trying to summarize in a comprehensible way the interactions of various antiepileptics. It's already incredibly outdated, even though it's just from like 5 or 6 years ago, because the number of chemotherapy agents, especially the ones in the molecular targeted category, it's really exploding. But this data is out there, and you can kind of hopefully make a rational decision rather than end up with a complication. The thing that I see the most that's frustrating is, again, and the example I'd use that people I think are more aware of is when you're dealing with an HIV positive patient is you don't want to put them on an agent blissfully unaware that you're reducing the levels of their chemotherapy. And that happens all the time. So people who are on molecular targeted therapies, if you're not using basically Keppra or Vimpat, you really want to check and be careful because their oncologist isn't going to know this. And the pharmacy, I don't think they've ever caught it in my experience. So if people are on a molecular targeted therapy, you really want to be cognizant of that because it's easy to just proceed and not even know that you've driven the levels of their chemotherapy down and made it ineffective. We can skip over this. So how am I doing for time? Okay, so I'm over. I got a little time. So whole brain radiation is still an effective modality. Um, Everyone fears the memory problems, but for some patients who have bulky and multiple metastases, it still should be in the armamentarium for treatment. The main advantage is for radiosensitive types of tumors, you can get rapid palliation and really kind of treat the whole area, especially for people with leptomeningeal disease. People with leptomeningeal disease, they really need a treatment that is going to encompass their cerebrospinal fluid, which SRS typically does not. So for people who have multiple miliary leptomeningeal mets are at high risk for them. People like breast mets in the cerebellum usually are leptomeningeal, whether we know it or not. You still want to really think about whole brain radiation despite the concerns about memory. People talk a lot about the radiation being a threat to their memory, but for every single one of these patients, their tumor is a far greater threat to their memory than the radiation. You know, I'm sorry, but that's a multiple choice test. Yes, I'm worried about the radiation affecting the patient's memory, but I'm far, far, far more concerned about their tumor. So that's kind of the balanced strategy that should be in your mind. And this is out there, patients know it. They don't want to get whole brain, and I understand why. And there are options, and you can make intelligent choices now based on some of the data we have and this prognostic data and what I use it for. The neurocognitive effects don't happen immediately. So in people who are in really one of the poor prognostic categories, you kind of can reassure them that they shouldn't be worried about the long-term consequences of the radiation on their memory. But they should be concerned about the short-term consequences of tumor control for their memory. People who are older and have uncontrolled vascular risk factors clearly have a higher risk of memory problems from any form of radiation. And then the other thing is medications. You know, we often don't talk about it, but if you take people and put them on steroids and most antiepileptics and do neurocognitive testing, all these other medicines we give them are also hitting their cognition and their memory significantly, so they are part of the story. We might be making a slight impact on the memory problems from whole brain radiation. There was a large phase 2 randomized study using memantine given together with radiation, and it seemed to have at least a partial protective effect in decreasing and delaying memory consequences for patients. It's a very well tolerated, safe drug. So they're doing follow-up studies incorporating memantine. ACE inhibitors surprisingly might have a slight protective role, so they're gonna give those in the trial. And then what they're attempting to do that's a little more unknown at this point is use hippocampal avoidance. So they can do whole brain radiation, but do it in a way that spares the hippocampi. That may make a significant impact, but of course for people with leptomeningeal disease, we're worried that anywhere you spare, you're gonna end up with tumor recurrence. So if that is effective, we're gonna have to figure out how to predict who we can safely give it to and who we cannot, and have to really give traditional whole brain radiation therapy. So whole brain radiation therapy may be changing in the next few years depending on how this phase 3 trial proceeds, and it may make it a better modality and better tolerated for a larger number of patients. This is kind of the old data just using whole brain radiation alone that I think everyone's aware of, that it is an effective modality, but it's often not employed for fear of the memory problems. But if you go to evidence-based, it's going to still be the standard of care for most evidence-based because the evidence is way outdated. Stereotactic radiosurgery is wonderfully employed, and most people who deal with these patients are huge fans of it. It's not for everybody, but I think we're learning better how to risk stratify who does really still need whole brain radiation, but many patients are much better served both short and long term by stereotactic radiosurgery. You can achieve much higher doses. People often don't think or talk about this, but different kinds of tumors and cancers have different sensitivities. So things like lymphoma, most adenocarcinomas, you really don't need that high doses to get a good durable response. Whereas other kinds of tumors, squamous, melanoma, renal, you really need high doses. So it's another way that people often don't talk about what modality they should use, but it's a very, very important factor. If you give whole brain radiation to somebody with renal or with a squamous or melanoma, you're not really going to get to a good dose that you should expect to treat it. So those patients really probably can only reasonably be treated with stereotactic radiosurgery just based on that alone and not the other things we talk about. The local control rates are extremely high with stereotactic radiosurgery. There is a risk of necrosis and edema, especially with larger tumors. So that's something we talk a lot about at Tumor Board. You know, oh, if we SRS that thing, are we going to end up with swelling and bad symptoms and somebody stuck on steroids for months on end? Which is also something we see with meningiomas. So some of these patients are better served by a resection or even just a modest debulking, because if you can decrease the volume of treatment that needs to be given, you're much less likely to have symptomatic edema. So sometimes treating people with both is really important. There are multiple different systems that are used or devices. This place is very, very unique. I don't know of anywhere else in the world that has both the Gamma knife and the Cyber knife. Do you? And because we often talk about them as like they're interchangeable. Gamma knife, Cyber knife, whichever, they all work. Don't worry about what kind. But our radiation colleagues here who work with both and show us the plans, depending on location, shape that they're trying to treat, either machine can have really kind of different side effect profiles and different access to different parts of the brain. So it's a really unique situation here that we have people who kind of work with both types of the commonly used machines. And I don't know anywhere else like it. And so it's great that the patients can get that kind of focused treatment with either choice here. Stereotactic radiosurgery, Dr. Cobbs and I are working on a guideline to try and sort out who should get what and when you should use which modality, which is challenging because all the studies were done with mixed populations. So it's kind of trying to retrofit the data and go back and say, well, who really should be better treated with one or the other? Kind of the old criteria was based on number of METs, and that's really quite clear that that's not the only factor, and it's probably nowhere close to the most important factor. Total volume of the METs that are being treated is probably the most important thing, actually, for who's going to have side effects of one form of treatment versus the other, and then what kind of tumor you're treating, and whether you need SRS to get to a dose that's likely to control the disease. So those two are probably the most important factors. And then the third is probably the prognosis of the patient as a whole. So taking a step back and saying, is this somebody with hormone-positive breast cancer who is very likely to be doing well 2 and 3 years down the road, and we need to kind of plan on that and keep them geared up for success there? Or is this somebody who has an aggressive lung cancer that is not EGFR mutant, where putting them through whole brain radiation that takes 2-3 weeks and then delays them being able to start effective systemic chemotherapy might really be a negative thing to do to the patient, whereas SRS, you can treat them in a day or two and you could start chemo the next day. So sometimes you have to really work with the oncologist to factor what you need to do for the whole person and not just be thinking about the brain and making an integrated plan for them. Unfortunately, most tumor boards at places not like here and major cancer centers, they don't really have all of the necessary people together to make these decisions. And a lot of it really depends on meeting the patient. You can't say it just from looking at a picture because the KPS is really important. And then really talking to the patient about their goals. There are people who say, I want you to do whatever it takes to keep me alive as long as possible. I don't care about side effects. And there are other people who will say, no, I don't want to do something to myself or go through something, even if it's going to make me live longer. So you really have to tailor the treatment for the patient because the modalities you choose and how you employ them are going to impact how they live both in the short and long term. So some of these tumor boards that meet where half the people there have never even met the patient, I think that's a big disservice. So I'm really happy to be here where we can work together, we've all met the patient, and we can really talk about for an individual focused treatment for that person in particular, and not just saying based on the brain picture where nobody in the room even knows what's going on in the body or what the treatment options there are. So hopefully more cancer centers will move towards that model. This is also kind of a beginning of trying to figure out who should get SRS versus whole brain radiation, where the prognosis, the tumor type, and the tumor volume, the total brain tumor volume, are probably the biggest factors, but other things are going to creep in there. that you need to factor in. So it's really a complicated decision. There's not a one-size-fits-all approach by any means, but there's often a lot of bias from either patients or in individual treatment centers where people say, no, everyone should get SRS. No, whole brain is the standard. Anyone who employs one modality universally is not really doing a good service to their individual patients. Radiation injury is kind of interesting because we all talk about the late effects in terms of memory, but people probably move through multiple phases. I described to patients radiation's like a sunburn, and it ages everything it touches. So there's also an acute effect of radiation, and there was a super interesting study that just came out. We all know this, we've all seen it when you deal with these patients. There's people who right at the end of radiation in the weeks thereafter, they're kind of just in this fog. It's very, very common. They'll have headaches, they'll feel cloudy, they'll be a little cognitively slow, a little off balance, then they just say they kind of don't feel good. It often improves within a week or two with or without using steroids. The thought that it was kind of an immediate vascular reaction and kind of subclinical CSF inflammation makes sense and had some data to support it. But recently there was a study done where they basically did spinal taps on people who had kind of the most obvious side effects, and a very large number of them clearly had reactivation of their CMV virus, which normally you would never think of except in people who were like transplant patients or people who had like end-stage AIDS. CMV really should not get reactivated, but people being treated with whole brain radiation alone, no chemotherapy at all, who should have an intact immune system, had an incredibly high incidence of this. It's extremely treatable. You put people on valganciclovir and they're better, literally within 24 to 48 hours. So we may be missing this, and it was not rare. This is probably extremely common. The other thing that people miss, but I think are at least slightly aware of, is it is very clear that even focal radiation can induce focal reactivation of zoster and herpes. Really, really common. See it all the time, often kind of subclinical, but probably occurs more often than we realize, that people who get whole brain radiation or even focal SRS, within a week or two, there they are with a cold sore, or there they are with shingles, and sometimes you can literally map out where the nerve that got radiated was. And they often don't feel well, as anyone would who's going through shingles. It does cause a systemic inflammatory syndrome. When you have those people, you slap them on Valtrex, in 24 to 48 hours, they're much better. And this can clearly happen with radiation alone. Occasionally, you also see people who will come in, usually within a week or two of any form of radiation, but more often with whole brain, with herpes encephalitis. And it's very, very easy to miss it because you say, well, of course they have a seizure from their brain met that just got treated. It swelled, they're having a seizure, that's all that's going on. But we did a study when I was at Sloan, and we found that the incidence of like true, frank herpes encephalitis in people who had gotten any form of brain radiation was about 1 in 400, which is a rare number, but the normal incidence would be 1 in a million. And the vast majority of them had gotten no chemotherapy. Quite a few of them were not even on steroids, although the steroids are a cofactor in animal models. So when you see these people coming in sick shortly after radiation, you want to think about these unusual infections and reactivations because they're kind of easy to miss, but they're very, very treatable. The other kind of late side effects of radiation of any modality, when you see these people months later, necrosis is common. It can be quite symptomatic. On imaging, it's almost impossible to differentiate a necrotic tumor from treatment versus a tumor that's progressing. The challenge, people say, well, why don't you get tissue? If the lesion was surgically accessible, it would have been resected before. So usually these are lesions that are in a spot that is not easy to get to. And of course, with a lot of tumors, when you talk about biopsy in a surgically sensitive area, then you have to worry about hemorrhage. So this can be a big, big challenge, and often these people go through periods of months where we're saying to them, this might just be necrosis, just stay on steroids and it's going to get better, or it might be that your tumor is progressing because it didn't respond to treatment, and we just don't know. PET is sometimes helpful for this purpose and easy enough to do, and I think underutilized, but it's nowhere near 100% accurate. It's probably in the 80 to 90% accuracy range. So you also have to be careful about MRI interpretation. Often the radiologist has no idea what treatment the patient got. Necrosis is probably more common in people who are on concomitant chemotherapies that act as radiosensitizers. It's clearly more common with SRS. So you really need to prep patients with SRS for that and say, just a heads up, in 3 to 6 months, your imaging might look worse, you might feel worse, and we just have to ride it out before we really know what's going on. And I think it's important to prep patients and families that they may enter a period of uncertainty about what's happening with them. And sometimes people just kind of make an assumption one way or the other. And you know, I've seen patients sent to hospice for what was just necrosis, and 3 months later they're much better and they come out. And that's also kind of not rare. Long-term consequences of radiation beyond memory issues are really vasculopathy. So some of these people years and decades later will be presenting with strokes and aneurysms, kind of an interesting syndrome where they go through periodic vasospasm that can present with weird headaches that are migraine-like and seizures, and they'll have kind of these transient white matter lesions in their MRI. The people for whom this is really important is outcomes from pediatric cancers are wildly different. So we are now seeing more and more adults who are survivors of childhood cancers, especially things like ALL, Hodgkin's lymphoma, who get mantle cell radiation, and people with pediatric brain tumors like medulloblastomas and germ cell tumors that are always treated with whole brain and sometimes craniospinal radiation. And a lot of times people say, well, that happened and now they're fine, they look fine. But these people have cognitive issues, they have hormonal long-term issues. And for a lot of us, what people don't know is they have a very high incidence of stroke. So some of these people in their 30s and 40s with no vascular risk factors have a significant risk of stroke. There's actually a guideline recommendation that people are pretty unaware of from the pediatric oncology community that these people should probably get screened because they often will have significant vascular disease. So the recommendation is you listen to their carotids. If I have any concern, I literally just send them for ultrasounds of carotids or MRAs and tell them that they need to not be smokers, obviously, but also be really keenly aware of their cholesterol, their blood pressure. So that's another thing that we often don't talk about or think about, but I think we're going to need to be more attentive to as cancer treatment and outcomes improve in the future. Talking about surgery versus SRS is really complicated, so it's really nice to be somewhere where our surgeons, I don't have to worry about it because they know and they'll make the right decision. Surgery versus SRS, there are some trials, but again, it's always about location. And then another cofactor that's very important in the decision is how likely is this tumor to respond to the SRS? So if it's something like that's very radiosensitive, like hormone-positive breast cancer or an adenocarcinoma that you can expect to just shrink away quickly from SRS, that's one situation. Whereas a bulky tumor that is radio-resistant like melanoma, you don't want to just rely that the SRS is going to take care of it. So you need to factor in the tumor type to these decisions, obviously always location and volume. I'm running short on time now. Yes. So I'll stop here, but I think the takeaway is that prognosis for these patients is wildly different, and it's about to become much, much, much more different. But I think you need to think of that when you treat the patients and when you pick treatment modalities, depending on the different tumor types and the subtypes. We're finally getting effective systemic therapies, and that spectrum is broadening. For a long time, it was just the HER2 positive breast cancer. Now it's also the EGFR mutant lung cancer. Now it's the BRAF mutant melanomas, and that the number of subtypes for which we have effective systemic therapies is kind of rapidly expanding. So it's an exciting time as a neuro-oncologist to be working with these patients and actually seeing them do better and better with treatments that are less and less toxic. So, any questions?